thank you first to the organizing committee for inviting me to speak today. This is great and just an amazing, amazing meeting. My colleague and I, Jalili Ojodu from APHL, were just talking about the impact this meeting is having, and we are very much impressed by what you've all done here in Alabama. So thank you very much for inviting us. This is my first time to Alabama, so I've been very lucky to have Conecuh County sausage, which was fabulous, so thank you. And had the best grits of my life last night, so thank you very much for that as well. So getting back to using this meeting, or the strength of this meeting, we'd really love to be able to use this meeting as a model for other states. So I've been talking to Cindy over lunch, thinking of how we can do that, because I think this is a great way to bring everybody from around a state together. So congratulations to all of you for the work you've been doing. I am representing NewSTEPs, which is the Newborn Screening Technical Assistance and Evaluation Program. And we are a HRSA-funded activity, funded by a cooperative agreement from HRSA. And I won't read through our mission and vision here, but really the purpose of NewSTEPs is to support newborn screening programs and the broader newborn screening system throughout the United States, to help programs utilize accurate and relevant information to achieve and maintain excellence in their newborn screening systems. I'm going to spend some time with you today talking about data to support the newborn screening systems and some of the current trends in newborn screening. As part of NewSTEPs, we have a national data repository for newborn screening, and this repository has data entered from all 50 states, plus the District of Columbia and Puerto Rico, and all states have participated in this at some level, including the state of Alabama, and we use the data from that repository to understand the trends of what's going on in newborn screening throughout the country. And it's data from this repository that I'm going to share with you today. So the map, I don't know if you can actually see the outlines of the state on the screen. There's actually a map of the United States here. And this is one way that if you want to look at your favorite state, in this case the state of Alabama, you can go to our website, www.newsteps.org, click on the state of Alabama, and you'll find out a lot of information about what's going on in the Alabama newborn screening program. And a lot of the data that I'm going to display today has come from that state profile information. So that's one area of information that we collect from states. In addition to that, we collect quality indicators, much like the 3 hospitals that were just highlighted today with the work they've been doing on improving unsatisfactory specimens. That's one of our quality indicators. How does the state of Alabama compare to other states across the country? So we're currently collecting that information in kind of this first iteration of our quality indicator data, and this time next year we should have some data to come back and say, yeah, here's how states compare to each other. Then we also have data on cases identified with a newborn screening disorder. Other information about newborn screened disorders and the infants with those disorders. When were they diagnosed? What was the timing? And what was the diagnostic information that was available to the state to really assess the certainty of that diagnosis? And I'll get to that in a little bit. To kind of guide our talk through the newborn screening system today, I'm going to be using this newborn screening, we call it the newborn screening process model, starting from birth in the upper left-hand corner, and that blue section at the top is that pre-analytic phase of newborn screening. Then we have the analytic to post-analytic phase of newborn screening there in the orange, and down in the bottom left you'll see there's the rules and regulations. What guides states and how they're doing their newborn screening testing? So I don't expect you to capture all of this now. I'll walk you through it as we go through the talk. So first, pre-analytic. First thing that happens in newborn screening is the birth of a baby, right? Annual number of births in the U.S., most of us from most states that aren't New York or California say, we're from a small state. We're all from small states, right? Well, actually, we're not all from small states. The median number of births, so the middle number, across all states is about 52,000. Alabama is right there just above the median at 60,000. So you're not a small state. You're a slightly bigger than the average state, right? And there's a lot of states in that middle range. So when we're looking at states, and what we do at NewSTEPs is try to say, how can we help support state newborn screening programs? How can we pair them with other states that are similar to them? Sometimes it's helpful to be paired with somebody who's a similar size. And there's a lot of states that are about that similar size in that, 40 to 60,000 range. And these states out here might have very different needs, the very, very small states and the very large states that are over 100,000 births per year. In addition, we know that birth rates vary per state. You can see the very darkest states here, and that would be Utah, have the highest number of births per capita, per 1,000 population. And then the lighter states have fewer births. And that may point to different needs as far as public health resources and access to those resources and the number of births they have to support. And what do we know about our newborn screening system across the U.S.? Well, there are 52 newborn screening programs that we're representing here today that include the 50 states, District of Columbia, and Puerto Rico. There are 36 newborn screening labs. As was mentioned earlier this morning, some of our programs are actually use the resources of other regional labs, such as in the state of Oregon and the New England Newborn Screening Program. So other states send their samples to those labs. But our states, not only do we have differences in the number of births, we are geographically diverse. So one state, it's 663,000 square miles to 1,212 square miles. So we're very diverse. There's a lot of differences that we need to think about when we're talking about newborn screening programs. So now going back to our model, thinking of that pre-analytic phase, and that's what so many of you in this room are really involved in, is that pre-analytic, the collection, consent, storage, timing of the newborn screening. So the consent models for newborn screening. Participation in newborn screening is assumed in most states. By that I mean babies are included in the newborn screening process and parents have the right to opt out of it, but there really isn't a consent process in most of our programs. One state requires newborn screening with no option to opt out, but most states do allow parents to opt out of newborn screening for various reasons, including religious or other reasons. And the state of Alabama is one of those states that allows families to opt out for religious reasons. I'm not going to go into a lot of detail about this opting out process, but I would point you to this publication here that was done by Dr. Jeremy Penn from the state of North Dakota, where he interviewed states, and I'm sure he interviewed someone in this room for the state of Alabama, to find out if you do refuse, what type of documentation do you get on that refusal. So for those of you in the hospital, you think about if a parent says they're not going to participate in newborn screening, why is that? Why don't they want to participate? And what kind of documentation do you send to the public health department to say, here's why have they refused? There's a lot of information in this. There's a link that I have here, and I'm happy to share these slides with the group so you can follow this link. But again, you can see that there's a few states that allow you to refuse for any reason, some for religious reasons, and then some that have no provisions for refusal at all. So now once we have that, how long do we store those samples? Does everybody in the room know how long Alabama stores their samples? A couple people do. This is the dried blood spot retention time. And the darker times here, the states that are colored in darker, store their samples for longer periods of time. In fact, the darkest ones store their samples indefinitely. And the lighter colored states store their samples for less than 6 months. And that's where Alabama falls, is the state that stores their samples for 3 months. This variation is really, there's a lot of reasons for this variation. In some cases, it's lack of storage. Some cases it's the states like California, New York that store them for a long time are doing a lot of research on those samples as well. But you can see there's a lot of variation in that. But it's important for you all to know, as someone comes to you and asks, what's going to happen to my sample? You can say, well, it's going to be destroyed after 3 months. What about the data that comes with that sample? So you think about not just the sample itself, but then we store a bunch of data on the abnormal and the normal samples. So on the left side here is the normal specimens and how long we store the normal specimens related to newborn screening, or the data related to those samples. And you can see that, again, the darker blue is storing it for the longer period of time, 20 years or more, and the lighter colors are those who are storing it for a shorter period of time. The red states in both of these situations are states who have no data retention policy, and the gray are states that we are still waiting to get data from those particular individual states. So you see on the left the normal data retention policy. Alabama is storing that normal data for a long time, indefinitely, 20 years or more, and also for the abnormals it's the same. Some states have different policies for their abnormal versus normal data specimen data retention. Now, timeliness. We heard some hints. Cindy talked a little bit about timeliness and thinking about how those awards for the hospitals will be in the upcoming years. Timeliness has had a really big impact in newborn screening recently. We've been talking a lot about it at the local and national levels. And these are the national timeliness recommendations. The Secretary's Advisory Committee for Heritable Disorders in Newborns and Children recently approved these recommendations. And I'm not going to read through them here. Hopefully many of you have seen them. But this is really to make sure that we get newborn screening done in a timely manner and the results get back to those babies who really need to get it back quickly. We heard this morning from the parents who said, boy, that timeliness is really important, and the earlier those diagnoses could have happened, the better off for those children. So they're broken into a couple categories. The first one is the presumptive positive results for time-critical conditions. There's 13 disorders that have been determined to be time-critical. MCAD's right at the top of that list. So think of those things that we need to identify in the first few days of life and get them into treatment as quickly as possible. Or something like cystic fibrosis, still a critical condition to identify, but doesn't have that time criticality to it. So it's time critical conditions. The next one is all other conditions. So 5 days for time critical. All other conditions are 7 days. And then all newborn screening tests should be completed within 7 days of life. So you think of all of the components of newborn screening that all of you are involved in: collecting the sample, shipping it to the lab. Well, and collecting a sample is not simple, right? Collecting the sample, letting it dry. We saw the drying rack in the previous presentations. All of those steps, when do those happen? And that all impacts our ability to get this back out to the lab, have the lab do the work that they need to do, and then call out those results within 5 days of life. It has to be really a well-oiled machine to make that work. So in addition to that, in order to achieve those goals and further reduce the delays, the advisory committee said initial newborn screening specimens should be collected in the appropriate time frame for a baby's condition, but no later than 48 hours of life. And they should be received in the laboratory as soon as possible, which is ideally within 24 hours of collection. So these are some pretty high goals to make. And there's a lot of us around the country saying, can we do this? But we're really working towards getting to these goals. This, in many cases, outlying hospitals, this could be a challenge. But let's work together to figure out how we can reach some of those challenges. So I'm going to present some data here from our newborn screening data repository at NewSTEPs. And this is a small sample size. This is about 1,000 babies that are represented here from a variety of states, from about 10 states. So it's not all states are represented, and I'll tell you in these data slides that look like this, these box plots, the state of Alabama does not have data in these particular slides. But these are cases of disorders diagnosed with newborn screening. So newborns who are reported to our repository, you have a disorder on the newborn screen, states with a signed memo of understanding. And so as states are entering this type of data into our repository, they have a memo of understanding in order to do that. And this does not include all disorders. It's a subset of the disorders. And this is when was the specimen collected. And for those of you who don't think in box plots like I do, I know some of you are data people, but some of you might not think in box plots all the time. Let me orient you to this. So the middle line in that box is the median, or the 50th percentile. So half of the samples were collected later than that, and half the samples were earlier than that. The upper and lower lines around that box are the 25th on the lower end and the 75th percentile on the upper end. And then 95% of all of the data falls between those two, what we call whiskers, those two long bars. And the little dots that are up at the top, those are the outliers. Those are the ones that didn't fit into that 95th percentile. So you can see, if you think of that recommendation of we should be collecting these samples within 24 to 48 hours of life, well, overall, we're doing pretty good. We're right about 40 hours, a little under. That's pretty good as the median. But then we can look for areas for improvement, that some of these samples aren't being collected until 100 hours, 150 hours, or 200 hours of life. So this gives us an opportunity to go back and say, wow, this happened to happen very frequently in one particular state. Can we go back to that state and identify what that is? And we don't know any additional information from this particular slide. Are those babies in the NICU? Was there something else going on? What was happening with that child? But this gives us the opportunity to look at quality improvement. So then we can look at it by state. What's the state variation in specimen collection? And we've blinded the states here, so they're just states 1 through 8 in this case. And you can see that there's quite a bit of variation. In state 1, you see they're almost always collected right around 24 hours of life. That median is 24 hours. And all of them are collected really by about 80 hours of life. Where you look in maybe state 7 or 8, you see some of those that are really way up there, and there's some outliers. So again, this gives us a chance to learn from various states. How can we learn what's one state doing? Maybe it's pulling everyone together in a meeting like this, educating people, talking through things, and problem solving together. And if that's the case, we can use those lessons and help other states out with that. So moving on to our next section, thinking of shipping and couriers. How do we get the samples from the hospitals to the state lab? And then once they arrive at the lab, what are the hours of operation and what's the staffing? So here's courier service usage across the U.S. Now, this is a very colorful slide, and I know those of you in the back might not be able to read all of the different colors. So the green is those programs who provide a courier service by the state public health department provides courier service for use by birthing centers. Where the blue is states who recommend a courier service, that all hospitals should use a courier service. The orange are classified as others, and typically most of those orange states also really do use a courier service. But they wanted to give us a little more information, so they checked other and typed in additional information, but most of those states also use courier service. So you see that blue, orange, and green, most states are using some sort of courier service to get the samples to the lab. And you can see in Alabama, the state really recommends all samples should be delivered to the public health laboratory using a courier. Now, states are changing the policies for the delivery of samples. And very recently, we've had a lot of notoriety in newborn screening related to the delivery of the dried blood spot samples to the lab. And so in this case, Tennessee added a courier service, paid for the courier service from the state of Tennessee, and have kind of rolled it out in an iterative process to their hospitals. So throughout various regions, over the past 6 or 8 months, they've been adding that courier service, so more and more hospitals have that courier service to deliver the samples to the hospital. They've received some great press because of this. This is a big deal in the state of Tennessee. And I'm going to show you some data to show that they really have made some improvements in when those samples are being received by the lab. So what I really want you to focus on here is the number of samples. This is received by lab, and it's displayed by various time frames. So here we have the purple bar that's pretty small, as those are received the same day as collection. Then we have 1 day, 2 days, 3 days, and 4 days. And you see that 1 day, 2 day, and 3 day. Follow that red bar down in the bottom in January 2015, and watch how that red bar moves farther and farther to the right. That just within a few months of implementing a courier service, most of their samples are received within 3 days of birth. So this is pretty impressive, right? That they collect the sample and are able to get it there within 3 days of birth. And then look at that yellow bar. They're at almost 80% now. And these are data from back in June. This is just the first few months of them after having implemented a mandatory courier service. So I'm really looking forward to getting their next round of data from the state of Tennessee and seeing how they've continued to improve that. So now we look at weekend operating status. So if the samples can get there, you have a courier, they get there very quickly, but no one's there to receive the sample and actually run the sample through the lab. What do? It's not going to really help that particular baby. So we see on the left side, this is weekend lab status. Who is working in the lab on weekends? We have the dark purple is Saturday and Sunday. The orange is just Saturday, and then the lighter purple is no Saturday or Sunday hours. The left side is laboratory hours, and the right side is follow-up. Now, follow-up is a little tricky because many follow-up programs don't have official hours on weekends, but they do have follow-up personnel on call. So people could be on call and receiving that information. So if I had shown you the same slide from 5 years ago, you'd see very few states having weekend operating hours, and many states are moving towards adding Saturdays and even Sunday operating hours in order to better serve their populations. Colorado was one who recently added Saturday operating hours, and this is really to help improve that timeliness. In addition to adding the Saturday operating hours, they are also considering adding Sunday hours for some critical tests, and they've changed the courier delivery so that they don't have courier that delivers on Saturday because they didn't really have enough set up to do everything. So they have a delivery now that delivers on Sunday. Maybe actually, let me take that back. They actually have delivery service all 7 days of the week. So the samples that come in on Sunday are ready to be run first thing Monday morning. So even though no one's at the lab to start that, they're ready to run first thing Monday morning, again, saving that critical time. This data is hot off the press for the state of Colorado. And here I want you to focus on that purple and green. So purple is 0 to 2 days being received by the lab, and orange is 3 to 4 days. So they've decided to clump their data a little bit differently than what Tennessee did. But you see that purple and green bar moving to the right as you look up in time. January at the bottom, up through the latest data is actually from August here. And 85% of their samples are received in 0 to 2 days. There's still some samples that are received in 3 to 4 days, but that bar keeps getting much and much smaller. So now it's 95% of samples are being received by 3 to 4 days of life. So this is very impressive. They are getting it there very quickly. Additional screening practices in states. Now we're going to go down here at the bottom, looking at rules and regulations. So what do states do for one or two screen do they have one or two screen specimens standard in their states? And how do they decide which disorders are going to be screened? So this is the number of screens, 1 versus 2 screen states. The purple states are those that have 2 screens, either mandatory in their state, or 1 screen is mandatory and the second screen is highly recommended to be done. And Alabama is one of those 2 screen states. And so you see Alabama, and then there's a lot of states in the West that do this as well, the 2 screen, 1 versus 2 screens. And there's going to be a talk later today on the benefits of doing a second screen, especially for endocrine disorders. It's actually used for many other disorders as well. I'd also draw your attention to a paper that recently came out that they did a study across states who had a 1 versus 2 screen. And this was led by Stuart Shapiro from the CDC. Jalili Ojadu was also involved in this. And this is a very tough study to do, right? Because you're looking at 2 states, or various states who have different screening algorithms. And because they have 1 or 2 screens, their cutoffs are different based on those 1 or 2 screens. So sometimes it's hard to actually draw conclusions about that. So what the 2 screen states will say is we find a lot of babies who are identified on that second screen that we would not have identified on the first screen. This paper works very nicely through all of that data and says that is true, but it's not clear whether if you change your algorithms, maybe you'd find them on the first screen. So I still think there's a lot of research to be done here, and we still need to understand this 1 versus 2 screen a little bit better. So newborn screening fees. What are we charging to do newborn screening across the country? The lightest states here charge the least. Some states don't have a newborn screening fee and fund newborn screening through other mechanisms. And the darkest states are charging the most. So there's some states that are charging upwards of $150 for newborn screening. So the state of Alabama is at the upper end of that range. And this is a question we get a lot in NewSTEPs, is what are the fees and what should my fee be and how should we consider this? And it's very different from state to state as far as what services you provide with newborn screening, what do these fees pay for, and what other resources do you have to pay for your newborn screening program. So what is covered by newborn screening fees? This is across various states. What do states cover in newborn screening? They cover program administration, lab tests, the information technology, IT support, short-term follow-up services, courier services, long-term follow-up services. Some have contracts for long-term follow-up, a biobank program, metabolic foods and formulas. There's a wide range of things that are covered by various newborn screening programs. So the next, maybe not, this one should be the most popular question we get, is what are states screening for? Who's screening for what? How do I know what's being screened for in my state? So there is a recommended uniform screening panel that was really described very nicely this morning that currently has 32 disorders on the panel. The 33rd and 34th disorder are currently on the desk of the Secretary of Health and Human Services for her to review. So how do you count the disorders? If a state says I'm screening for 52 things, what does that mean? So we've counted the disorders and broken them down in different buckets. There's the core disorders, there's the secondary disorders, and then there's other disorders you might screen for. And we really primarily count those that are screened for on the recommended uniform screening panel. So this is the list of the recommended uniform screening panel. I know you can't read it. I'd encourage you to go to the HRSA website. You can see it. There's 32 disorders here. And these are the things that almost all states have adopted almost all of these. So we're looking at 32 disorders that most states have, and I'll show you what that distribution looks like in just a minute. And then there's a secondary panel. And these are things that haven't actually in many cases been evaluated on their own by the Secretary of Health and Human Services and her committee. But yet, you might find them when you're doing regular, typical newborn screening. And if you're going to find them while you're doing that newborn screening, it probably benefits the child for them to know about them. So some of these things include those other various hemoglobinopathies that, yeah, that's could be important for that family to know about, but it hasn't been evaluated. They haven't been evaluated on their own. So secondary disorders are disorders that can be detected in the differential diagnosis of a core disorder. There's the 32 core disorders, and those ones on that last slide I showed you are the secondary disorders that can be identified. So here's the screening of the 32 core disorders. The darkest states are screening for all 32 of them, and going down through the heat map to the lightest states. And you notice the state of Alabama is screening for 30 of them. So the two that aren't being screened for currently in Alabama are SCID, and we heard about that a little bit this morning, that it's on its way, it's getting close. And I'll talk about that a little bit more in a minute. As well as Pompe. And Pompe was just added to the recommended uniform screening panel in March. And so very few states are actually screening for Pompe yet. So I'd say Alabama's right there in the mix with where everybody else is. There's a lot of states who are screening for 30 disorders. So national progress in SCID implementation. The next slides I'm going to show you, I'm going to go through pretty quickly. This is a kind of a virtual animation of what it's looked like in SCID and how SCID has moved across the country. So here's 2008, which had the state of Wisconsin. We added Massachusetts. Then we kept adding a couple more states. 2011, 12, really had a big boom in 13, 2014, 2015. We're almost there. And based on what we know from what's going on in the state of Alabama, and some other states, 2016 is we're going to have almost the entire country. So the planned implementation for the state of Alabama for SCID is in 2016. So Alabama received a SCID grant from APHL. We were lucky enough at APHL and NewSTEPs to be the recipient of a larger grant from HRSA to help support states doing SCID implementation. So we had 12 grantees. They were awarded up to $150,000 a year for 2 years. And Alabama was one of those states. They're utilizing their funds to support the laboratory efforts and to facilitate SCID implementation, and expected, we think, by August of 2016. So this is really exciting. And for those of you who aren't familiar with SCID, and even familiar with this process, it takes a while to get new disorders up and running in a state laboratory. There's a lot of things that have to be in place. And SCID was a unique laboratory test that it brought molecular testing into the lab for the first time in many cases. And it's a new process. And so it's a challenging test to get up and running. And we're very excited that Alabama will be added to the group of orange states by hopefully this time next year. So what about CCHD, critical congenital heart disease? We heard from a mom this morning who had a child with a CCHD that was diagnosed. And let me show you the same type of map with CCHD. So here's 2012, 2013. I want you to see, again, you guys are all probably already paying attention to Alabama. It takes me a minute to pay attention to where I'm about. So Alabama's added relatively early for CCHD implementation. 2014, 2015, and by 2016, this time next year, we again expect most states to be screening for critical congenital heart defects. One of the challenges in CCHD is that this is a point of care test where hospitals are having to report data back to the state public health lab. Well, there's variability in what that data collection looks like. Many states have no data reporting at all, that they're not really getting much information from hospitals on what's happening with the screen. Some hospitals are sending aggregate data to their state public health department that, yes, we screened 50 babies last month and 2 of them failed, and that's what you get at the state public health lab. And all the way up to some hospitals giving all pulse oximetry values from all babies to their public health system. And that really is dependent on a lot of things, but the legislation that was passed and the rules and regulations in the state really dictate that. In Alabama, really the guidelines state that the submitting healthcare provider shall report the results of any failed pulse oximetry screen results to the Department of Health. So just the failed results and not all of them. So again, I think it's right in the mix of kind of typical of what's happening. From an epidemiologist perspective, in my profession, I would love to have more data so we can say, how is the screen really working across different hospitals? And Cindy could be producing some report cards saying, wow, your CCHD screening is doing really good in your local hospital, and here's some areas for improvement as well. But it's a big challenge to collect some of that data. And here's Pompe screening status. And I'm not going to go into a lot of details here other than it was just added in March of this year, and so very few states are screening for Pompe. Here's other disorders that are screened in the U.S. These are ones that are screened not on the core or secondary panels, but these are things that other states are screening for. So you can look on there and find your favorite disorder, see how many states are screening for it. If you want more information, I would encourage you to go to our website. We have a screened condition report. You can click on that and pull up other conditions that are being screened within a given state. How are states making decisions and policies? What's happening? How do they decide what to screen for? Well, most states do have advisory committees in the U.S., although there are some states who do not have an advisory committee. Some are mandated by statute or law, and some are voluntary. And so the green states are voluntary, and that's where Alabama falls, and some are mandated by law, and those are the blue states. And then there's a few states, those red states, who currently don't have an advisory committee and make decisions within their Board of Health. Here's a composition of advisory committees. There was one that was presented earlier this morning as well. This is kind of breaking it down to a little more detail of who's on an advisory committee. And especially those states who don't have advisory committees will call us and say, hey, who do other people invite to be on it? But as we in Colorado were revisiting our advisory committee, we thought, let's go look and see who do other states have on their advisory committees. Okay, so now I want to get into this orange section, the analytic to post-analytic part of newborn screening. So now we look at the timeliness. We've talked a little bit about timeliness. How do we break up that timeliness? There's lots of different components. There's those of you who work in a hospital, there's that component of newborn screening. Then there's the delivery and the actual laboratory testing, and then the follow-up. So we've divided up here birth to receipt by lab, birth to report of results, birth to intervention, and then finally birth to diagnosis. And you can see that kind of stair-step there. Now many people, I talk to a lot of students who say, shouldn't diagnosis happen before intervention? And the way we define intervention here is when someone has called the family and said, you need to stop doing something. Or, in the case of MCAD, it might be they call and say, don't let this baby fast. And that's that intervention, because that MCAD newborn screen came back as abnormal. Somebody calls the family and says, don't let the baby fast, we're going to see you first thing in the morning. That intervention happened then, baby comes in, they start the evaluation, but it might take a while for that evaluation to be confirmed and have that diagnosis in place. So we really want to be able to capture the intervention and the diagnosis. Now you look at this and say, okay, that birth to receipt by lab, that doesn't mean anything, I can't actually see those numbers, so we pulled them apart for you. So here's birth to receipt by lab, and you can see that for the most part, the median is at 4 days of life. That's great. We're receiving those samples on average about 4 days of life. However, again, there's quite a bit of variability there and room for improvement. What's happening to those samples that are taking 45 days to get to the state lab? Did they get lost? Did somebody batch them? What happened? So that gives us, again, opportunity for quality improvement. Time to release of out-of-range results. Now, this is across all disorders, but the Secretary's Advisory Committee says we'd like to release those out-of-range results by 5 days of life. So in here, we're at about 7 days of life, so we're getting pretty close. We're not quite there, but there's, again, quite a bit of variability. Why has it taken so long for some of these babies to get their out-of-range results? And these are babies with disorders on the newborn screen, so things that we want to identify early. And time to intervention. I'll let you absorb that for just a minute. Again, quite a bit of variability. And I don't want to spend too much time on these together. Here's time to confirm diagnosis. Because the astute ones in the audience will be saying, but Marcy, why don't you spread these out by disease, right? Because time to intervention for MCAD is very likely going to be different than it is for cystic fibrosis, right? We need to intervene very early in MCAD. So here we have time to receive by lab by disorder, and we wouldn't expect to see any difference because we don't know what disorder kids have when they come in. So I'm just presenting this to show it's pretty similar, but based on small numbers. But now we get into something that's more interesting, time to release of out-of-range results by disorder. So you look on the right side, you see MCAD, and those release of out-of-range results is happening pretty early, median by 5 days of life. That's fabulous. That's what the advisory committee is recommending. For cystic fibrosis, it's taken a little bit longer because in most cases for cystic fibrosis, most states are doing an IRT and then a DNA, so the laboratory testing is a little bit longer, and the critical nature of cystic fibrosis is a little different. So we can look at this and say, are there some cases that we should be worried? Okay, well, there's a PKU case there that the out-of-range result didn't get called out until 20 days of life. What's going on with that? again, giving us the opportunity to contact the states and say, hey, how can we help support you? Are there ways that we could help problem solve with this? And sometimes it's hard to do when you only have one PKU case in a year in a given state. You might not be able to see what those trends are. When we can pull trends together from around the nation, we can look at it and say, hey, you are one of the superstars in this area, and this is fabulous, and here's an area where you could, we could maybe find some room for improvement. So similarly, time to intervention by disorder, you can see that time to intervention is quite variable across all of these different disorders. MCAD and PKU, very early. That's fabulous. The hemoglobinopathies are a little bit later. Now we might say, what's going on there? Could we improve in those hemoglobinopathies a little bit? And I'm just going to caution you here, this is based on a few states with small numbers of babies. So once we have more states, next time we come back to talk at this symposium, we'll have hopefully much more data and be able to give you a little more precise estimates here of what this looks like across different states. And then time to confirm diagnosis by disorder. You can see that in some cases, so flip back, I want you to just pay attention here to MCAD and PKU. Look at time to intervention for those disorders. Intervention's happening really, really early. These babies are getting into care. They might be put on the right formula or being, that intervention is happening, so we know the detrimental effects of the disorder is not going to occur, and then you go on to confirmed diagnosis. It takes a lot longer for that confirmed diagnosis. But that's okay because they've already entered into care. So it might take another couple of months, or in some cases up to a year, to confirm that diagnosis with genetic testing and identifying their specific mutations. So now I'm going to move on to the last section, and that's the section of the confirming that diagnosis. So we do collect information on babies who are diagnosed with a disorder, and we're really trying to categorize them appropriately. And so we have case definitions for newborn screening that really were developed by the broader newborn screening community and the clinical subspecialists. And the purpose of these are to provide an accurate characterization of the frequency of these newborn screening disorders and really give systematic definitions that can be helpful at the local and national levels. So thinking about a specific case, and I'm not talking about cystic fibrosis because it's the one that's I've worked with for the longest. So you imagine a newborn with an abnormal CF newborn screening, had an IRT of 105 nanograms per ml, the normal range is 60. The DNA analysis revealed an F508 and an R117H with a 1790. So those of you who aren't familiar with CF, sometimes that mutation, that genotype, is associated with cystic fibrosis, typically more of a mild pancreatic sufficient type of cystic fibrosis, but sometimes people with this genotype might not ever go on to develop disease. So now we've identified this kid on newborn screening, what do? So they're referred to the CF Center for a sweat test, and the sweat test comes back with 25 micromoles per liter, where a diagnostic is greater than 60. So what do we do with that? Do we say the kid doesn't have CF? Do we not have CF? So we compare them to the case definition. But first, this baby goes to see a clinician. Let's say the baby goes to see Dr. Smith. The baby likely has CF, says Dr. Smith. Let's follow this baby regularly, and we're going to tell the family the baby has CF, because based on my experience and my clinical evaluation of this baby, I think this baby has CF. Dr. Jones says this baby has CRMS, cystic fibrosis-related metabolic syndrome. So this is a special diagnosis that really has come about because of newborn screening. But we say, we don't know what this baby has. So it's not CF, but maybe the baby will develop CF, so we really need to follow them and follow them every 6 months to see if the baby develops CF symptoms. But if the baby saw Dr. Garcia might say, you know what, the baby's fine. No symptoms, no CRMS, no diagnosis, the baby does not need to be seen. Now, all three of these opinions are based on that clinician's knowledge and evaluation of that baby. And absolutely appropriate, and our case definitions are not intended to second-guess that case definition from a clinician. However, from a public health surveillance standpoint and how we collect things at the public health level, we need to be able to count them similarly in Alabama, in Colorado, and in Maryland. So we're all doing it in the same way. So based on our surveillance case definitions, we'd enter this into an algorithm, and this newborn would be classified as CRMS, as a baby who we should probably still be following and find out what happens to them long term. But these definitions do not impact the clinical diagnosis. They're not meant to second guess, just meant really for public health surveillance and for counting. But it would, in this case, will help us to better understand the burden of CRMS in the U.S. and to appropriately classify babies as CF or CRMS. Now, I gave you that example there of 3 fictitious doctors who might have given those different diagnoses, but I've seen that happen in one hospital in Colorado, where different doctors will have different opinions. Absolutely what we want them to do. We want them to judge their clinical management on their own opinions and their knowledge. But from the public health perspective, we want to be able to classify them correctly, so we can classify them and count them correctly from year to year and from state to state across the nation. So I want to end with some efforts to support newborn screening timeliness and programs throughout the U.S. We have, we're a little over halfway through a quality improvement initiative called CollN, a Collaborative Improvement and Innovation Network, where we had 8 states who were participating in continuous quality improvement activities. They came together for an in-person meeting. We really worked closely with them to improve their timeliness in newborn screening. The 8 states are listed there. It's a 15-month project. Teams of 5 individuals came, met us at in the APHL headquarters in Silver Spring. We did some training there on quality improvement activities, and now we have monthly calls. And the data that you saw from Tennessee and Colorado were a large part due to those quality improvement activities. So it's really an opportunity to share ideas and collaborate to find solutions across newborn screening. In this case, we really looked at the time to receipt by lab for that specimen. So we have many people from hospitals partnering with individuals from the state public health department to figure out where are those places that we can find improvement in our given states. So building from that, we're really excited to announce a funding opportunity called NewSTEPs 360. This funding for us started September 1st, and we will be supporting 20 state newborn screening programs to improve timeliness over the next 3 years. This builds on the success of our CollN opportunity. It's a competitive funding opportunity. Applications will be released the week of September 21st, which is next week. So I'd really encourage Alabama to be thinking about how could you be approaching timeliness, and this is timeliness from birth to diagnosis. How could we be improving timeliness in newborn screening while building up that quality improvement network within the state? So please visit our website at newsteps.org for more information, and keep an eye on your emails, because we'll be sending that out via email as well. And then finally we have what we call Project Instant Gratification, or PIGS. And in honor of the Conecuh County sausage, I thought we should put up the pigs and you could see our adorable pig. But this is our way to give tools back to newborn screening programs. So we have a series of Did You Know emails where we say, hey, here's something cool that a different state is doing. And as I've been watching this, I would love to have a Did You Know email that highlights, hey, did you know that Alabama did a really cool newborn screening symposium that invited people in from around the state? We do things that highlight states, that highlight overall data, various different programs that are going on in the United States. We also have the run charts that I presented earlier, and we're developing personalized quality indicator reports that will show you how do you compare to other states. And so what have we learned and where do we go from here? So we're very excited at NewSTEPs to be working with state newborn screening programs, really to develop and strengthen the newborn screening system, or develop solutions for and strengthen the newborn screening system. And we're looking at that by really collecting data in a quality, controlled way, so we have good data that we can provide back to you to make comparisons, to provide technical assistance, and then to bring people together to share ideas and expertise. And I couldn't do this alone. I'm so excited to be working with this great team of individuals that's both from APHL, the Association of Public Health Laboratories, and from the Colorado School of Public Health. And if you don't know, this is Newborn Screening Awareness Month, and Baby's First Test has a kind of a challenge out there for all of us to talk about why newborn screening matters. In this case, we said newborn screening matters because it brings compassionate people together to make a difference in the lives of every baby. So with that, I thank you very much for your attention.